Hello, 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 hello.
చోటు కిందది కిందది ఫీమేల్ అది
మేడం అక్కడ ఒకటి ఉంది, ఇక్కడ ఒకటి ఉంది.
ఓకే ఓకే మేడం సార్ వాయిస్
Hello, 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 hello.
ఇది కాదు మేడం మాది
ఇంకోటి చూసుకోవాలి.
A very good afternoon to all of you. Warm welcome from Department of Accident, Trauma and Emergency Medicine, Department of Guntur Medical College, Guntur. Welcome to the Global Advances in Emergency Medical Care 2024, an exclusive Advanced Emergency Medical Care workshop. I am Dr. Radhika, Professor HOD of Emergency Medicine Department at Government General Hospital, Guntur, Guntur Medical College, Guntur. And it's my privilege that we were able to do this program in such a short notice, and we were able to have an eminent personality here who has been in the field of resuscitation for the past 30 years, who has been working with American Heart Association since last 30 years. It's none other than Dr. Vemuri S. Murthy garu. I would like to introduce Dr. Vemuri Murthy sir. Privilege that I have been given this opportunity to introduce him. Very warm welcome to you, sir, to Guntur Medical College. Dr. Vemuri Murthy garu is an alumnus of Guntur Medical College, Andhra Pradesh. He is a 1968 batch of GMC, an All India Institute of Medical Sciences, New Delhi General Surgery postgraduate, a US anesthesiologist and chairman of the department at West Suburban Medical Center, Oak Park, Illinois for over 3 decades. He is an adjunct associate professor in the Department of Emergency Medicine, University of Illinois, College Medicine, Chicago, Illinois, involved with Indo-US global health projects. Hailed as a pioneer of resuscitation medicine in India and global champion of resuscitation, he is an educator, trainer, and researcher in the field of resuscitation medicine. He pioneered an Indian medical university resuscitation education and training model at Dr. NTR University of Health Sciences, Andhra Pradesh in 2012. He has been a visiting professor to various medical institutes such as AIIMS Mangalagiri and Dr. NTR University of Health Sciences in Andhra Pradesh. Dr. Murthy sir was the honorary advisor CPR to the Odisha state government in the Department of Health and Family Welfare 2023 and 24, involved with statewide CPR training projects to enhance bystander CPR outcomes in sudden cardiac arrest. Honorable President of India, Mrs. Draupadi Murmu, commended Dr. Murthy's contributions to CPR projects in 2023. Dr. Murthy is a guide and co-investigator of groundbreaking Indo-US resuscitation research projects and a cardiac arrest registry, Warangal area out-of-hospital cardiac arrest registry 2018, and contributed to several research articles and book chapters. He is the founder of the US Community CPR Project SMILE of the Chicago Medical Society, Illinois, and National India Hub Community Health and CPR Training Center in Illinois. He was also the past president of the Chicago Medical Society and Indian American Medical Association, Illinois. Dr. Murthy served the American Heart Association in various capacities, including U.S. National Faculty, member of the International Committee, and advisor to International Training Centers, India. He chaired international scientific programs and lectured at the prestigious U.S. medical institutions such as Brigham, Harvard, and Baylor, Houston. Dr. Vemuri S. Murthy's decades of contribution to global health, resuscitation medicine, and community service were recognized with several prestigious national and international awards, including Global Champion of Resuscitation Medal from U.S. Congressmen and Lifetime Achievement and Distinguished Physician Awards from dignitaries such as the former Vice President of India, Mr. Venkaiah Naidu Garu, and ambassadors of various countries. Indian Medical Association, India instituted an oration in Dr. Murthy's name at the annual conventions recognizing his decades of contributions to resuscitation medicine in India. It's a great privilege to have you here, sir, and we welcome you, and thank you very much, sir.
Thank you, Radhika. Can we lower the lights, please, completely? And also, I request those who are sitting in the back to kindly come to the front. And also, let me know if you can understand what I am saying without much echo. Can you listen to me? Okay. Can you please come, because this is like an interactive session, that I would love to do, because we're part and parcel of this great institution. And thanks again for coming today. I tell you, today is a great historic day for me, because when I joined in 1968, and we never had a lot of facilities that you guys are having now. And, thanks to Gymkhana and other organizations, we are able to accomplish today what you're enjoying. So consider me as your friend. Consider me as somebody that can participate with some of the programs with you. And I just would like to, today we have got a 3-hour presentation, and it really, you all inspire me whenever I come here, having involved with the resuscitation medicine for past 35 years with different organizations, including the American Heart Association. My heart really goes out to the younger generation. That's where you have to start your career. Whatever you want to do, you have to start looking for it when you are a first-year medical student. The first-year medical students, have a lot of energy when compared to somebody like me. But I will try my best, to be a part and parcel of the younger generation too, And I think, you always have to dream big. Dream big, and at the same time, you work hard. Success comes on its own if you work hard. But again, we're not worried about the ultimate result. If you have made adequate effort to accomplish something, and that matters. Failures are steps to more success, and don't get disappointed if there are some shortcomings, roadblocks during your career. The life goes on, and at the same time, the science, almost like I left for United States in 1979. It's almost like 45 years I've been in Chicago. I come here once or twice a year as a visiting professor and give some workshops. So today, how many of you are medical students? Any medical students? Residents? Nurses? Paramedics? Faculty? So, I'm trying to start from the basics of adult cardiac resuscitation. And I will take you to the most advanced artificial intelligence technology, which most of you might not be aware. I brought a robotic module, and that module, I got close to about 90 cases to discuss. So you interact with that module, with that robot, so that any kind of mistake you commit not on the human beings, but on robotics, using robotic technology. So with that brief introduction, I'm going to proceed with the updates on adult resuscitation. When I say updates, usually the updates are given by organizations like American Heart Association, say every 5 years. Now the knowledge is expanding so rapidly that whatever I say today may not be 100% correct in the next year or so. So when we say updates, the updates we should do at least every 6 months to 1 year. And this is an evolving medicine, resuscitation medicine, which never existed when I was in charge of the emergency department at All India Institute of Medical Sciences in New Delhi, 1979. Sudden cardiac arrest. Sudden cardiac arrest is the biggest challenge we are facing. Of course, the cardiac disease is the main issue, but I will slowly take you to, starting from the bare essentials right up to the top of what 2025 can give you. I don't have any conflicts of interest. As you know, heart disease is the biggest, number one, killer, number one, enemy, no matter wherever you live, United States, India, or Australia. And if you look at the incidence of heart disease, obviously, high-income countries have the heart disease. Upper middle-income countries have the heart disease. Low middle and low-income countries. So it is ubiquitous. It is universal. Nobody is spared. Cardiac arrest, stoppage of the heart, affects more than 600,000 people in the United States. The overall survival to hospital discharge in 2020 in adults resuscitated from out-of-hospital cardiac arrest was only 9%. So, whereas in in-hospital cardiac arrest, it was 23%. Well, obviously, you have got the physicians, the specialists, and you have the resources, you have got the experienced intensive care staff, including the nurses. So, still, the incidence of survival is only 23% inside the hospital. Whereas outside it is miserable, 9%. So far as India is concerned, we don't have a lot of statistics from India. We really need to do the registries. That means based upon the international format, then we know we can define, we can identify the depth of the problem. In fact, I'm very proud to say that myself and my cardiology colleagues from India, as well as the University of Illinois, we had the first cardiac arrest registry based upon international format published from India about 8 years ago. It is called the WACAR, Warangal Area Cardiac Arrest Registry. This is the first registry from India where we went in depth to define the various aspects of the anatomy of the heart disease, cardiac arrest, and all that with the information that we barely have. And I'm hoping that every hospital will start a registry and then go to the regional level, state level, and then the national level. Again, this is my experience, I can share with you. Whatever the guidelines that you are exposed to, whatever the practice you do, they may not be applicable to your next city, adjacent city. In other words, there are so many variables, so many factors that influence the outcomes. So we'll come to that later. But again, there is no universal formula. So that's why they are called guidelines. Again, I have to remind you, whether you are in United States, Australia, Japan, or India, the guidelines are more or less the same, except your emergency number is 108, in the United States 911, and definitely there are certain things, that are different in different countries. But basically, the medications, the approach, the quality definement of the structure of the resuscitation is more or less the same, because we are human beings wherever we are. So in India, again, the survival from sudden cardiac arrest is less than 10%. What makes us unique as South Asians is we are highly vulnerable, highly prone to early onset cardiac disease for various reasons. Whether it is hypertension, metabolic syndrome, diabetes, lack of exercise, diet, high in fat, genetic, maybe 6%. So as South Asians, as Indians, and Indian diaspora in the United States or England or anywhere, we are the number one target. I have seen and managed people with acute MI suddenly dying with so-called sudden occlusion of the left coronary artery. It's called the widowmaker. It's very difficult to survive. At the age of 20, at the age of 25. We're not talking about somebody having a heart attack at 80. We're talking about the heart attack, cardiac disease, rampant among younger generation that really bothers us. Stress. Stress is a very major factor besides other things. It's an independent variable. It directly affects the myocardium. So our focus should be to have the knowledge from all over the world and then tailored to Guntur, tailored to Tamil Nadu, tailored to Odisha. So it is important for us to gather all information. And after all, one person is different from another person. Now I'm going to talk briefly about some of the things. Cardiac pathogenesis. This is the most recent diagram. So we can classify as primarily structural, something wrong with the structure of the heart itself. It could be anything. Electrical. The classic example in India or anywhere where the cricket or the baseball is played extensively as a national sport. That is a classic example of primary electrical dysfunction of the ball hitting your chest and suddenly stopping the heart. There are also primary ischemia. That is the third factor for the pathogenesis. Now, this is very sad. See, in science, we speak the truth. Evidence-based medicine. We don't try to hide the information. If I'm wrong, I will say I'm wrong. If I say, that this needs substantial exploration before we call translational medicine. First you have to develop a concept, and that thesis you have to prove, go to the lab. Then you do a lot of RCTs, randomized controlled trials, not just the studies that somebody has done. Retroactive helps, the so-called observational studies, But randomized controlled trials, it is the standard for any kind of research that you're going to do. It costs money. It costs not 1 lakh, 2 lakh, 3 lakhs. It costs multiple crores and crores of rupees if you are serious about doing the RCTs. And that's where organizations like American Heart Association come from. $100 million are spent every year by the American Heart Association to propagate, to develop the research, cardiac research. So, it's a shame. There is no reduction in the number of sudden cardiac deaths globally. So, and this is what we acknowledge. In spite of our best efforts, in spite of the best technology we embrace, in spite of so many organizations working hand in hand, we did not make much, we don't have much success to have a significant impact on the quality of the outcomes. But we keep on going. We just keep on going, because after all, the civilization changes not in 10 years or 100 years, for hundreds and hundreds of years, for the cultural revolution to come to fruition. Now, in hospital cardiac arrest, this is a 2019 data from Journal of American Medical Association. As you can see, it is extremely difficult to produce any kind of rational, explanation for any of these things, because we lack data. We need data. Without data, there is no scientific progress. And again, as I said, translational medicine, where you are going to translate a theory, starting from the lab, right up to through the bedside to the community. So that is the translational medicine. It costs a lot of time, effort, and governmental support besides funding. As you can see, the non-shockable rhythm in in-hospital cardiac arrest is 80%, asystole and PEA. These are the deadly rhythms. The easiest rhythm to convert, I'm sure the cardiologists might have done here, emergency room physicians, anesthesiology, faculty, everybody is represented here, I think. You know how relatively, I wouldn't say easy, how relatively you can approach ventricular fibrillation as opposed to asystole or PEA. And again, the survival, as I mentioned, is unfortunately not what we really would like to see to our satisfaction. There are two things I would like you to focus on. Number one, quantitative. If you manage a patient, and this patient, irrespective of the age, is going to live long, 5, 10, 15, 16, 100 years. That is quantitative analysis. But equally, and in my books, it's much more important, is the cognitive function. And that is very important. I will come to that later. Why brain protection, the neuroplasticity, we will come to that. And so we're talking about the quality of the, quantity of the life and quality of the life. Both are important, but in my books, the quality is more important. Because if somebody develops inability to recognize dementia or any kind of loss of the mental faculty, and that takes a lot of toll on not only the person, the people surrounding him, the family, the friends, and eventually the society and the nation. Okay. It's important to have, these are three important words. Diagnosis specific. You diagnosed one, myocardial infarction. So, timely. Time is the essence. And precise interventions are the key factors for successful resuscitation outcomes. That's why diagnosis is important, and your intervention should be timely as well as precise. You know what to do. You should know what to do. Now, as you can see, look at on the top. You all know. That is, what's the rhythm? Fibrillation. Now, When you talk about fibrillation, there is only one way of reversing it fast, whether it is ventricular tachycardia or ventricular fibrillation. Just use electricity. You can use a defibrillator. That's it. When there is asystole, obviously, you can't use a defibrillator. You have to use high-quality CPR and then epinephrine. And tarsats. Besides these things, you have to use magnesium. So that's what I'm saying. Diagnosis-specific, timely, and correct intervention is mandatory if you are looking for the quality. Then, somebody has cardiac arrest. So I'm talking only about the cardiac disease and cardiac arrest. Somebody has, you are there, you revived the person, and as you know, return of spontaneous circulation. So when you feel the pulse, okay, ideally the outcome is good when the ROSC is obtained within 15 minutes. That's very important. So you obtain the ROSC, and then you should think immediately, what is the cause of the sudden cardiac arrest? Is it the cricket ball hitting, or is it acute myocardial infarction, or is it a pulmonary embolus, or pericardial tamponade, or drugs, or drowning, pneumothorax, ruptured thoracic aorta? You should know, because your entire management after the feeling of the pulse depends upon your quick, specific, accurate diagnosis. So you have to understand that. Now I'll give you some examples. Now you can see, I don't have a pointer. Now this is acute MI, and there is more than 80% obstruction of the proximal part of the left coronary artery. It is called the widowmaker. I don't know why they call widowmaker. So this almost majority of the patients having this kind of sudden occlusion, because as you know, the left coronary artery supplies the majority of the heart muscle. And when the circulation is impeded, there is no way that you can save the patient in majority of the cases. Now, same thing about, I will also try to play the video. You can see a thrombus that can lead to pulmonary embolus. That becomes pulmonary embolus and can occlude the pulmonary artery. Then they cause sudden cardiac arrest. Same thing, pericardial, acute pericardial tamponade. We're not talking about chronic pericardial effusions and all that, sudden bleeding into the pericardial space. Oh, this is a beautiful day in the afternoon in Chicago. We don't get, we are not getting a lot of snow these days, thanks to global warming. And again, I'm happy I'm here, whereas in Chicago, it is cold. I think I was told 2 days ago it was like wind chill of -20, where here in Guntur I'm enjoying 78. Basic life support is the foundation for successful outcomes. You do whatever you want to do. You can do the, cardiac intervention, anything you do later, but basic life support, without a perfect basic life support, there is no advanced cardiovascular life support. I want you to do that. Basic life support is the foundation of advanced cardiovascular life support and further futuristic modalities of cardiac intervention. I just want you to do not ignore the basic life support. Now, I'm going to show the American Heart Association's chain of survival. A chain is a system where we have now 6 links. The chain is strong only when each link is strong. If the first link is strong, second link is weak, it doesn't work. So you need to have a very strong chain supported by very strong links, 6 links. Now, I'm just going to say, for example, the out-of-hospital cardiac arrest. The first activation of the emergency response, 108. That is the first link, very important link. All the links, in fact, they're very important. The next one is high-quality CPR. We're not talking about CPR. We're talking about high-quality CPR. We'll talk about it later. Defibrillation is the third link. Then advanced resuscitation, when you have a well-equipped ambulance system where the resuscitation is continuing until the final destination of an acute cardiac care center is available. And it is very important. We need to have a very strong ambulance system. And the ambulance should have the latest technology. More importantly, the personnel need to be trained, retrained, retrained. Because we know that during the course of the training, if you take ACLS course today, you will become rusted in 6 to 8 weeks unless you practice the skills. So that is what is needed. It's not just taking the exam, getting your certificate every 2 years. No, it doesn't work. Because if you do not consistently practice the same thing that you have done in the first session, you will be rusted. The next one is, of course, the post-cardiac arrest care. It's a big subject, post-cardiac arrest care. And then, of course, the recovery. Each and every link is very, very strong, should be very strong. And I can tell you, usually American Heart Association says, you teach the hands-on CPR for children about 12, okay? Why? Because the muscles usually, this is just a ballpark number. And I've seen 10-year-old kids being more robust than 25-year-olds. Across the board, you really need to have a lot of strength in the muscles to do high-quality CPR. We'll come to that. Now, again, the basic and advanced life support. So these are the 3 things, that you really have to put one sequence after another. I'm not going to the details. So this is just the basic thing, and I'm sure most of you know about it. When somebody collapses, pulseless, of course, you don't feel the pulse if you're not a physician. And even for experts, it is very difficult to feel the pulse. Don't waste more than a few seconds to feel the pulse. Patient is not breathing and collapsed. Immediately, what you do is to call 108. Don't do anything. Don't touch the patient. Bring the patient to a hard surface, start high-quality compressions, and get an AED. I'm telling you honestly, in my experience and everybody's experience in the resuscitation field, if you don't have an AED, if you don't defibrillate within 3 to 5 minutes, you cannot revive the patient. That's the bottom line. You know why? In majority of the cases, you still have why hands-only CPR is promoted internationally on par with classic CPR. Classic CPR is both compressions as well as the breaths. That is absolutely, that is the golden, ultimate thing, But majority of the cases also survive if you do only hands-only CPR. But hands-only CPR is only effective for 5 minutes. After 6 minutes, we start with a room air of 21%. It gradually diminishes with cessation of circulation. After 6 minutes, every minute, the person is hypoxic, 10% of the brain is gone. So practically, when you see a person 10 minutes after the incident happens, sudden cardiac arrest, there is no way you can revive the brain, period. There are some situations where you cannot use, we don't recommend hands-only CPR. They are infants, people with pre-existing heart conditions, as well as the respiratory disease, drug abusers, drowning. So these are the categories of patients where you cannot just do hands-on CPR. You must do a classic CPR. The rest of the people, then you can do that. But again, whenever you do hands-on CPR, I'm not talking as physicians, You want to make sure that your position is safe and secure while you are providing the help. Okay. Now, this is the very classic diagram. I'm going to spend just 1 minute because of the lack of time. I got so much to cover. The subject I chose, unfortunately, I was given only 1 hour, but this lasts for about 3.5 to 4 hours. So, what do? You do the CPR after you call the 108, and if the defibrillator is available, just defibrillate. Two defibrillations, and every 2 minutes, of course, you can check the rhythm. So you can see 2 defibrillations and then epinephrine. Epinephrine is the only drug that is useful and recommended. And I don't want to go into the details of the dosage. Shock, CPR. Shock, CPR. Epinephrine, shock, CPR, and then amiodarone. And if the patient does not recover, there is no pulse, then you go to HSNTs, We'll go into that during demonstration. Now, this is called the Bean of Chicago, It's a beautiful monument. And Mr. Kapoor, Indo-British citizen, architect, and he is the one who designed this. It's a tourist attraction in downtown of Chicago, the Bean of Chicago. I am not going into the details of the doses and all that stuff. This is what I want to. I'm going to try to cover some of the things which usually don't hear. You can go and go to the CPR manual and learn those things. But these are things with my own experience and others' experience. Closed loop communication. It is extremely important. That means, if I say, give epinephrine, then the person who is designated to be the person pushing the drugs, he will say or she will say, epinephrine, 1 in 10,000, given IV. That is the closed loop. If I ask you, what is your name? You tell me your name, and that is closed loop. If you nod, if you don't pay attention, and if you do not respond to my question, that's not closed loop communication. One example I can tell you in the real life, there is a big code going on. Then suddenly the defibrillator died. So the in charge of the code, he said, get me another defibrillator. At the same time, one person left. And then they kept on doing it. 1 minute, 2 minutes, 3 minutes. The new defibrillator is not there. And after 5 minutes, the person who went there came back and then said, he was just standing there. What happened? Didn't you bring new defibrillator? He said, no, I went to make a phone call. This is exactly the lack of communication. Closed loop communication is the only way you connect with the other people. So please remember that. Also, I take this opportunity to introduce, I would like to see every every hospital to have the Code Blue team. And I am sure Guntur Government General Hospital here has the Code Blue team. This is extremely important to have a Code Blue team. And I can talk about it later on, time permitting. The main reason being, these are the designated people. If something happens in the middle of the night, and if they say Code Blue, OBGYN, whatever, floor, they are there within 30 seconds. They are ready. with the cart and all the medications and all that. So Code Blue team comes when the disaster has already happened. The patient collapsed. That is the Code Blue team's area. But there is another team, Rapid Response Team. The Rapid Response Team is the team that comes and prevents an impending disaster like cardiac arrest. Like I'll tell you a typical example. Somebody has been in the hospital for 20 days with high fever. The blood pressure is okay this morning, 100/60. Since 5 o'clock this afternoon, evening, it started to go slowly down. 90, now it is 70. That's where you have to call this particular team. Rapid sequence team prevents an impending disaster. And I would like to see in my alma mater both the teams functional when I come back. Thank you. Let us go to the maternal cardiac arrest. I'm not going to go into the details because of the lack of time. There is so much to cover. And I think Dr. Radhika started at 3:15. I got 25 minutes more. There are so many causes of the maternal cardiac arrest, as you know. Cardiovascular hemorrhage, amniotic fluid embolism, and of course anesthesia related. All these factors are there. Remember, you are dealing with 2 patients, not just one. So it has to be much more impactful, much more focused when you are dealing with the mother as well as the fetus, the baby. That's why it becomes much more intense. Again, you have to make sure whenever you compress, obviously, you don't want to compress on the stomach, which of course goes up and brings the diaphragm up. And of course, manual displacement of the uterus is extremely important. I'm not going into the details at all. And of course, avoid femoral lines and obtain IV access above the diaphragm. Again, this is something, I don't know if it is practical in some of the hospitals in the various countries that I usually visit, but you got 4 minutes after the cardiac arrest to deliver the baby. If there is a cardiac arrest, you really have to do the emergency cesarean within 4 minutes. Because if you lose the mother, you should not lose the baby either. For that, there must be, even big institutions are struggling or scrambling the resources, because this, if it happens in the emergency room, you can imagine. But I have seen some of the institutions practicing it on mannequins and doing an extremely good job. But this is an area where anesthesiologist, emergency room physician, OB/GYN, as well as an intensivist, and of course, I give a lot of credit for the nurses, the critical care nurses. So all these people, they form the life-saving team significantly more when there is a maternal cardiac arrest. And again, when we talk about these things, I always tell, do your best depending upon your resources. And we are not saying, that everybody has to do this. No. You stick to your resources. And, I would say, think global, act local. And so when I come and teach has been teaching for so long, I get a lot, from all of you, from any institution. I've been visiting professor to so many universities. Still, it makes me really humbling how you're struggling to maintain the quality with not many resources. Because I gave lectures at Harvard, I'm not comparing even some of the hospitals in the United States. We cannot compare apples and oranges. So, all that I'm requesting you to do, gain knowledge and do whatever you can, the best you can do under the circumstances. Opioid associated arrest. Now this is a global pandemic. Abuse of the drugs. No village, no city, no country is spared. You go anywhere, you got the sad story of the people stopping suddenly because of the drug abuse. It's a pestilence. It is worse than plague. And that's why I call it as a already emerged pandemic. Remember, the only medication that really can help in the initial stages is naloxone. And American Heart Association has already adopted the guidelines of using the naloxone, But again, you do whatever you can in your own institution. And here, just like in children, infants, the common cause of cardiac arrest is respiratory. So here, you have to pay more attention to the respiratory status of the patient who has been abusing drugs. Now, this is my favorite topic. I was involved with some of the brain research since I think in 2009 in Chicago area, where we didn't have a lot of resources either. There are 13 reasons why the brain is susceptible to oxidative stress. The most sensitive organ. There are so many factors. Mitochondrial disruption, apoptosis, which is the programmed death of the cells, electrolytes. You can see the neurotransmitter autooxidation and all these things. That's why I wonder if we are able to use our brain properly. We are very fortunate because none of these things happen. But if even one factor is ignored out of all these 13 factors, maybe there are 100 factors. This is just one diagram. So we have to take into consideration the brain, and of course after you revive, as the most important organ, because there is no regeneration of the brain cells. I'll come to that later. Neuroprognostication means when somebody is not waking up after a particular lethal incident. How do you know that this patient will wake up or will not wake up or will partially wake up or will wake up with a disability? Prognostication is extremely important, especially in this day and age of financial constraints. The healthcare system is taking a big chunk of the national, the economy. Every country, no exceptions. So there are some guidelines, again, neuroprognostication, where you have to do certain tests, again, at the right time. And that's important. But again, when you do all these tests, I come from Guntur Medical College. So we dissected about 3 dead bodies during anatomy of 1.5 years. So we know the importance, and we know the bedside you go, you examine the patient. We used to examine the patient for 45 minutes. It's not like, these days, I'm not talking about India, in general. Just go, somebody comes with a headache, get a CT scan of the head, without realizing that headache maybe is just something, maybe with a sinusitis or something, Clinical examination is number 1. The rest of the things, fall into the second place. So by combining all the information with your clinical judgment, you will be in a position to decide what to do. Because if you keep a patient on the ventilator for 5 months, 6 months, 8 months, and if he doesn't wake up, I wouldn't call it as an exercise in futility, but it is something that the other people who are equally deserve the same kind of treatment are deprived of this. So, I'm just showing you an important neuroprognostication diagram. When do you do head CT scan? When do you do enzymes? Neuron-specific enolase. The neurologists, they know. And this is also one of the critical enzymes, not only for the brain, but also for the heart. And that is helpful for the prognostication. The rest of the things, as you know, SSEPs and all that, I'm not going into the detail. But whatever the decision you make, whether to proceed with the life support or not, is multifactorial based upon the information that you gather at the correct time. Roadmap to recovery. This is a big deal. It's good. You resuscitate the patient. You took him to the cath lab. You did the catheterization. Now, he was discharged in 5 days. Great. But that's not great enough. Road to recovery is an extremely tedious process. Extremely tedious. And that's where the actual exposure to the post-cardiac arrest phase starts. You are talking about so many factors, impacting this road to recovery. Of course, we want everybody to have 100% recovery. You and I know that is impossible to accomplish that, the golden goal. So how you rehab the patient, how you follow up the patient. Most of the research papers, that I was involved with, the biggest challenge I have is the follow-up. You follow them up for 3 months, 5 months, 6 months, and they're lost. So I don't know. I have no idea what has happened to them. So it is a very challenging field. I'm just exposing you to this kind of mysterious process of how we are unable to accomplish 100% recovery after the fact. I'm just going to touch some of the cardiologists may ask, double sequential defibrillation. That means you are giving extra voltage, not through 2 pads, but 4 pads. But of course, there is not, for everything we say, do you have enough evidence to do this? And if it is not useful, that means it doesn't withstand the test of being a good RCT, then we don't recommend that. I mean, that's the basic thing we believe in. Now, I understand Dr. Radhika was mentioning that there is a mechanical compressor, And I'm just going to, I'm not advocating anything. I'm not promoting any product. Now, this is a gadget, as you know. Just compressions. It is important. Well, you know what? It has been approved in only certain conditions. Firstly, you should know how to assemble, how to bring it, and activate it within 2 to 3 minutes. Number 2, you need to have training for that. Number 3, which is equally important, is what are the indications? We don't have a lot of people in the night or even in the morning when somebody is doing continuously, 2 people, 3 people, 4 people, 6 people, they are doing, high quality CPR. It's the fatigue, human factor. We are human beings. We have limited energy, relatively speaking, to machines. So during transport, because this gives consistent, same quality compressions, and that's so it is recommended in institutions where there are experienced people to do that prolonged cardiac arrest intervention, and also during transport, they are useful, But in small hospitals, I think it is impossible. These are very expensive gadgets. I want to talk about the POCUS. How many of you are experienced with ultrasound, echocardiography? Okay, thank you. You must be a cardiologist. Point of care or neurologist, or it's extremely. This is the state of the art. My mentor, Professor Dr. Naveen Nanda, is called the father of echocardiography. So he always tells the basics. You really, every emergency room physician must, not should, must be experienced in doing a POCUS. What is POCUS? Point of care ultrasound. So you quickly put the probe and see if there is anything that you can diagnose within 2 minutes. Initially, we were very reluctant to use during CPR, but now we opened up with evidence-based information that we have. If you have a challenging situation where you are not getting the RASC or the return of spontaneous circulation after 10, 15 minutes of the process of resuscitation, then you should know, is there any reversible cause? So there are a few things you can diagnose with POCUS right away. It's non-invasive, right? So if you have a pericardial tamponade, you can diagnose that. Pneumothorax, you can diagnose that. Pulmonary embolus, you can diagnose that. Rupture of the aorta, you can diagnose that. So these are the specific conditions which will help, which are helpful. So in most of my international workshops, we make it a point to have an echocardiography workshop, 1 or 2 hours, and please, especially for the emergency room, and most of the cardiologists in this country, they are experts in doing the POCUS, but when it comes to the emergency room physicians, it is very important to have this kind of training from the beginning. It's not that difficult, You spend 2 days in a workshop, any workshop, you will know that. Again, emergency medicine is in infantile stage anywhere in the world. And that's why, again, as I said, there was no emergency medicine when in 1979, in the emergency department of AIIMS, New Delhi. Now, of course, they're on par with any other, nation, in doing these things, state-of-the-art things, So please, keep this in mind. Ultrasound may be helpful in some patients, and they will be thankful to you because they are saved with this. Okay. Drone technology. Drone technology, absolutely, in some countries like Sweden. Do you know, actually I gave an interview to one of the newspapers 4 days ago when I was doing the first Indo-US convention in Hyderabad. I mentioned that awareness of cardiac arrest is only about 1% in most of the countries. In Sweden, 80% of the people, roughly about 80% of the people, they know how to do CPR. Hands-on CPR, 80%. And in countries like Japan, when I travel to Japan, this is all I do instead of, sightseeing. AEDs are dime a dozen. You go to the hotel first floor, there are 2 AEDs. Second floor, 2 AEDs. I'm not exaggerating. Streets are studded with AEDs. And it's not just the AEDs are there. People know how to do that. There are people in the hotel. They know. 6, 7 people in one ship, they know how to do AEDs. That is where I would like to see our country progress in the next few years. Drone-delivered AEDs, they are useful in situations where there is excellence in cardiac care. For example, I'll give an example. In one of the most sophisticated countries like Sweden, if the ambulance comes in 3 minutes or 4 minutes, the AED is sent to your backyard 1 minute before the ambulance arrives. So that is the precision-driven, equipment. But again, even in the United States, we don't do. There are some places they are using it, but we don't have the drone system, especially in Chicago and all that stuff, because there are so many challenges you have to face, But I'm just throwing some more latest information with whatever knowledge I have, Okay. This is my favorite. Simulation. Simulation. I was trained in simulation almost like 10 years ago. And the moment I look at, this is an intermediate gadget. This is not the SimMan 3. And again, I want to thank Ledal. Whenever I come to India, two members come here and provide me all the information. This is not SimMan 3, but it's as good as SimMan 3 for ACLS. Without simulation, there is no future of any medicine in the world. You do whatever you want, simulation. And I'm going to show you the artificial intelligence-based simulation. It is really, really amazing how much you can gain by using the simulation and artificial intelligence technology. The concept of simulation came from a long time ago, from aeronautical engineering. As you all know, or at least some of you who are exposed to the aviation medicine, you know how the pilots get trained. It's all simulation. It's all simulation. And it is just like the games that our children play. And they will show you ups and downs. They will create problems. And then you should be able to solve it. So simulation technology is going to the main educational gadget that I would like to see in every medical institution in this country soon. I will tell you an example. As you know, the Wright brothers invented after so many years of struggle. Now look at this. If you look at the picture, what did you see? The plane landed on a lake called the Hudson Bay. This is the reality. This is United States Airways flight was an Airbus which climbed out of the New York City's LaGuardia Airport on January 15th, 2009. And then guess what happened? You know the birds, the Canadian geese, they came and sucked into the engine. Both engines stalled. Just a few minutes after they took off from the airport. What happened? Engine stopped. Then, because of the experienced pilot, again, simulation technology, they have decided, let us ditch this aircraft. That means let us bring the aircraft down into the Hudson Bay, water. Can you imagine how many people died? Out of 155 people, nobody died. Everybody was rescued thanks to the immediate transportation and all that stuff. So this is what I want you to remember. Our whole life will transform positively, provided you adopt the new technology. That goes without saying. Simulation in resuscitation training. You can have a very, very varied components like assessment, individual psychomotor skills, intervention skills, clinical problem skills, clinical reasoning. This is what happens in Chicago sometimes. When it is dark, we get thunders. And this is downtown Chicago with all the skyscrapers in the back. we have the pandemic, coronavirus disease, killing millions of people. These pandemics, they don't have any geographical barriers. It doesn't matter. I'm not going to go into the details, but I have to tell you, after the COVID-19 virus, so many people had post-COVID myocardial damage sequelae, long term. Even till today, after 6 years after the COVID-19's emergence on this planet, people are still suffering from the long COVID, besides losing mental faculties and all that. I talked about the hand solar CPR and public access, defibrillation, pregnant patients, and this is important. We really need to have, this is our paper, the WACAR, which also received an international award. I just want to tell you, these are all the results. Most common cause of out-of-hospital cardiac is, of course, cardiac etiology. Majority of them occurred in residential locations during the daytime. Hypertension, diabetes, and tobacco in any form, can contribute to as a risk factor. And we also published in 3 sequential American, the Society of Cardiology, Cardiological Society of India. We wrote chapters also, myself and my colleague, Dr. Ramaka from Warangal. So it is very important. I'm not going to discuss too much what some of the projects we are leading in Illinois Heart Rescue and all that. But one thing I have to tell you, Heart Rescue of India, this is one of the pioneering pilot projects in India. I was also a minor consultant. This is Indo-US collaboration. This is what the international collaborations do for us. We learn a lot, you learn a lot, we work together for the good of humanity. This is, I think, something like a $4.2 million project, which was, the funding was provided by Medtronic. Ramaya Medical College, we chose a perimeter of few kilometers, and then it's affiliated with my department at the University of Illinois. And so this is the first very, very robust program that really produced high results. When somebody has a heart attack, immediately the guy on the scooter will go. He does the 12-lead EKG, and immediately we follow all the guidelines. There are several hundreds of patients, who were treated like this. We are still waiting for some of the results, but I tell you, it is these collaborations that help us a lot. I'm not going to, this used to be in Chicago, 6 to 8 feet of snow. We don't see that. Cerebral protection, again, I don't have a lot of information, a lot of time to share this with, except that, I was involved with this, again, for more than 10 years. And when I will tell you, I will wrap it up in the next 5 minutes, Dr. Radhika. I will wrap it up in 5 minutes. I will wrap it in 5 minutes, because this is very important. When somebody is not waking up after the return of spontaneous circulation, then the resuscitation experts recommend you really need to do cooling, which is called the targeted temperature management. And there are so many papers that produced excellent results, but now they are also challenging it. Basically, after spending millions and millions of dollars, they have proven that hypothermia is a good modality of the brain recovery. I'm not going to go into the details at all. It is a 2-hour topic for me. However, recently, there are some studies that proven, you don't need to cool the patients. You really make sure that the patient does not have fever. So, the billion-dollar question is it the cooling in a particular range for 24 hours responsible for the recovery of the brain, or is it the prevention of fever? And there are so many organized institutions, including University of Illinois. We are studying the different times for cooling and all that. And hopefully in the next few years, or maybe 3-4 years, I will come back and give an exclusive presentation. But I just want to let you know that, this is the first paper that we produced. This was published in the American Journal of Respiratory and Critical Care in 2012. We spent almost like 5 years. Again, the resources were not there for us in those days, But you will see, the results are more or less the same. Cardiac arrest gets better results in a public place, witnessed arrest, cardiac etiology, bystander CPR, and if the ROSC is accomplished in 30 minutes, now we say ROSC should be accomplished in 15 minutes. So the science changes so rapidly, but sometimes some of the fundamentals remain the same. And again, I hope we've got the neurologists here, and when there is stroke, there is also, there is ample evidence proving that, the cooling of the body might be helpful. And I'm coming to an end. These are the IceCap studies we are doing at University of Illinois. And then we talk about again, as I mentioned, I've only touched a small portion of the global resuscitation education, but as Radhika was mentioning, as being the advisor to the government of Odisha, and I have seen so much of enthusiasm from the government of India, Ministry of Health, NELS program, National Emergency Life Support Program, is an excellent program tailored to India, and kudos to that. And I congratulate that Guntur Medical College, my alma mater, is one of the centers chosen for this among 3 in Andhra Pradesh. Thank you and congratulations. I also commend all my teachers, and I can mention lots of them: Lingam Surnan Garu, Kodan Rame Garu, Nashara Garu. These are all the legendary people, So this is my special tribute. And again, I thank you all from the bottom of my heart, because you are, especially the younger generation, you are the ones that will take India to any height beyond what you imagine today. Thank you. Hello? Hello? Now this is a simulation thing. And I request you, come here as volunteers. It doesn't matter if you're a medical student or faculty or a nurse or anybody, Dr. Radhika, you've been our student for a long time, 15 years. And, she will be the program director. And Avinash Rajan, he's going to talk briefly about it. Here is one of again, this is not the state-of-the-art simulator, but this is definitely a good, I don't know how many of you have seen this kind of demonstration. 1, 2, 3, 4, 5, 6, barely. So what I would like to do is, we will create a scenario. We'll create a scenario. And obviously, we're all troublemakers. We don't want to bring you to the Government General Hospital emergency room. A patient comes with chest pain, and he gets better in 5 minutes and he goes home. No. We will create a scenario. Eventually, he will have a cardiac arrest at some point. You may revive him, or you may not revive him. But I tell you, the protocol itself is vast. We are taking only 1 or 2 examples, So if you look at, we can show the EKG, whatever you are doing on the mannequin, okay? You can do anything on the mannequin, okay? But not on human beings. So We have got several gadgets there, and electrocardiogram, of course, saturation, end-tidal carbon dioxide, and all these things are there. What you do, okay, with your hands, and there is a team, a person. The head of this is Dr. Radhika. Radhika, you are the team leader. So, team leader doesn't mean that he is like God. No, anybody can be a team leader, but team leader is more experienced than others. Team leader will suggest the roles of everybody else. If you are an IV therapist, doesn't mean you are an inferior human being. Don't think like that. Everybody has a very major role. Today, at some point, you start the IV. During the next session, you'll become the team leader. This is important. Team, respect to the team, and make sure everything is done in appropriately. Again, what I'm talking about, the closed loop communication. That's important. And you should be like synchronous. It should follow absolutely a perfect art and science of resuscitation medicine brought to the living state in the gymkhana here. So, I'm going to create one. So, you select your team. You bring another microphone. So, Dr. Radhika, give a big round of applause. She is the team leader.
Thank you, sir. Thank you very much. Hi, friends.
You select anybody. You know what? Don't be afraid.
Whoever wants to
Don't
come
be
and
afraid.
volunteer can come. I already have two of my assistant professors, Dr. Harideep, assistant professor of emergency medicine department from AIIMS Mangalagiri, and Dr. Ravi Teja, assistant professor of emergency medicine department from Srikakulam Medical College. And I want my postgraduates also to come and join.
I think there is a lot of.
Oh, sorry.
Just keep
Yeah.
it little low.
Dr. Amita, Dr. Sonika, Dr. Shanmugam, Venkatesh, and Dr. Hanuma. So these are postgraduates of Guntur Medical College, Emergency Medicine Department. So we'll just run a mega code, sort of mega code simulation. Sir will be giving us the scenario. Or sir,
Well,
should I
actually-
take the privilege of
Well,
having my own scenario, or you want to give us?
Avinash, will you present a scenario? Okay, any scenario, I will tell you. We do all sorts of funny things here. Nobody will have in the real world. We'll have ventricular fibrillation, asystomy, atrial fibrillation, everything in 5-10 minutes. But we are going to show you. This is how you get energized, you get educated, So it's not just one phase. If you say, ventricular tachycardia, you gave a shot, the patient recovered. It doesn't work that way because we are going to challenge you. And that's where, the essence of learning through the mannequins. Go ahead. Now, what kind of scenario? We will be playing the role, and also, that's why I said, please come to the front, it's quite interesting, to see the rhythms and all that, how drastically they change. And again, this may not happen in the real life, but you should be prepared for it. Okay, Dr. Radhika, what is that you are going to see today on the screen?
Should I go ahead?
Yeah, Avinash, go ahead and introduce the topic.
Me being the team leader, I have to select my team, and my team consists of an airway person, circulation, and a person who connects the monitors, drug person, and one person who logs in the whole scenario, and one person who does the CPR. So,
Yeah, one second. Those sitting in the back, are you able to hear clearly? Yes? Because don't come to me then and say, no, we didn't hear anything, there's a lot of echo, please, okay? All right, I think maybe we should keep the microphone a little down and see. Yeah, go ahead.
So, Dr. Harideep will be the airway person, and Dr. Ravi Teja will become the CPR person, and Dr. Hanuma will be the person who gives the drugs.
Nijena?
Dr. Amita, I want her to be the person who brings the defibrillator.
Okay, maybe I think it's easy. Maybe it is easy when I take over a little bit.
So Dr. Hema will be the person who locks the whole. Can't hear. So Dr. Hema is the person who records the things. So every 2 minutes, she gives the heads up of what is happening, and finally, she will debrief what all that we have done. So debriefing will be done by Murthy sir. Sir, will you please?
Well, I will. Okay? Just don't go blindly and say, there is something going on. No. So, Avinash, create 161 or whatever it is, ventricular fibrillation or tachycardia, it doesn't matter. But please take away the saturation, take away the carbon dioxide, and there is no blood pressure. I'm yet to see a patient with a systolic of 119 when there is ventricular fibrillation.
So, Hardeep, take care of the airway, you take care of the circulation.
Wait.
CPR.
She is going to tell. Go ahead.
And the person is now in ventricular fibrillation. So check the pulse, immediately start CPR. And one person take the IV access, circulation person take the IV access. And be ready with 1 milligrams of epinephrine. Keep it loading and keep it ready. And the defibrillation person, get the defibrillator and get it ready for 200 joules. I am clear, you are clear, everyone clear? Shock to be delivered? Yeah? Switch the roles, start CPR again. So Dr. Hema, 2 minutes up. You have to tell us 2 minutes, 2 minutes up. 2 minutes up, check, again reassess, still ventricular fibrillation. So one more shock to be given. Okay. Continue CPR. Load 1 milligrams of epinephrine. Be ready with that. 2 minutes of CPR up. Reassess. Still ventricular fibrillation. Give one more shock and give 1 milligrams of epinephrine. Yes. And get ready with
Okay,
300
we'll take a
milligrams
break.
of amiodarone.
We'll take a break. I'm going to critique now. 1 second. Now, it's more than 3 minutes. Okay? The patient came and then he had sustained ventricular fibrillation. Okay?
Almost 6 minutes.
Correct.
Cycles.
Correct. So the first thing you do, and it's a good thing you already selected the team, but it will take only, you should not waste your time in selecting the people, whoever is there. So what did you do first? When you found ventricular fibrillation, you said get a defibrillator, right? Okay, it is already there in the emergency room. The scenario changes from place to place. There is already a defibrillator, and you have got excellent team. So what do you do first? As soon as you already put the patient on the monitors, what do you do next? Immediately, what do you do?
Immediately defibrillate.
Correct.
Anytime
Immediately.
you see a ventricular fibrillation, CPR, if it is available, immediately defibrillate.
Correct. Correct.
And then start CPR.
This is the message you have to carry home. We always say start high quality CPR first. There is nothing wrong. You do the high quality CPR absolutely while you are waiting for the defibrillator. Once the rhythm is VTAC or VFib, immediately defibrillate. And at that point,
VTAC
whether you have
without
done
pulse.
correct, and then it didn't recover. And then what did you do?
Immediately, electrical and chemical conversion.
Well, the first and foremost thing is, she has to do so many things. And she is calm. You cannot be nervous. Okay? Just like a pilot.
You have to take care of the
So what you do is, first you check the IV. IV is given, but again, it always happens, especially just in the things, when the IV you start always infiltrates. Okay? For IV, I want to tell you, how many of you are experienced in intra-osseous techniques? It's very important, because IV is a conduit for epinephrine and other drugs. So you don't want to waste time for starting an IV. Okay?
In a patient who is in collapse, making an IV access is really very difficult. So we always be ready with intraosseous placement of the needle.
Yeah.
So
what do? You must learn how to do intraosseous, especially obese patients. Patients with kidney disease and all that, it is extremely difficult to have vascular access, you know that. And it's very difficult to feel the femoral pulse. You don't have a femoral pulse to put the femoral catheter. So you must do the osseous. Intraosseous, especially in children. I think in the institution where I go to in the United States, almost 60% of the time they do intraosseous. And it is as efficacious as IV. Because IV has got very limitations. And this is another thing, do not try to start a central line when the cardiac arrest is being taken care of. Do not start a central line, no. You always have to do either IV quickly, get the best person, get the best IV therapist, okay, and then do the intraosseous. So intraosseous is very important, especially in children. That you have to do. Okay, you started the IV, and then you have
IV
somebody to do the oxygen, right?
IV became difficult, so they started intraosseous.
IV difficult, thank you. Then you get the intraosseous. You have done intraosseous. You are
Yes.
ahead of me. Good.
We have done
Intraosseous. And then what about oxygen status?
Oxygen
No,
status
forget
is-
about that. I'm asking. So you did defibrillate.
So,
After defibrillation, you have to do CPR for 2 minutes. 30 compressions, 2 breaths. 30 compressions,
2 ventilations.
30 compressions,
2 ventilations.
30 compressions,
2 ventilations.
30 compressions, 2, 5. 5 you have to do. And then you do defibrillate again.
Defibrillate.
Again, we are following the protocol.
So, in the meantime,
defibrillation.
we are making ready for the advanced airway also. Placement of advanced airway. And
So-
sometimes even placement of advanced airway is also difficult. So, in such circumstances, plan for cricothyroidotomy also. Cricothyroidotomy immediately. That is also easiest procedure in emergency room.
So, you are doing a good job. Your shoulders may hurt later. He's doing 30 compressions. How much of depth?
Depth is at least 2 inches.
Okay. You need to have recoil. Okay, what you're trying to do is when you're compressing against the spine on the flat surface. And so the ventricles, the blood is out of the ventricles. Then with the negative pulmonary pressure, now you have the negative pressure coming up. When there is negative intrathoracic pressure, the blood is sucked into both sides, both atria. So you really need to make sure that you do a good compression followed by the release. So both are equally important. Good. What about oxygen? I know he's doing a wonderful job. Every 30 compressions he's giving 2
ventilations.
Where is the bag, ambu bag? You don't have ambu bag? Okay, that's okay. Imagine. How much of oxygen you're using, Dr. Radhika?
We are using 100% oxygen.
Okay. Are you not concerned about so-called superoxide radicals and all that?
No.
No, not in the cardiac arrest. We are very much concerned about, hypoxia. Our aim is to get at least up to 92%, not 100%, not 98. We are happy with 92 to 94, and then you can cut. But in cardiac arrest, don't be chintzy. In cardiac arrest, you have to have 100% oxygen. That is needed for the brain. So you asked him to do it, but nothing has happened. So you gave 2 shocks. 2 shocks. And then what do you want to
1
next?
milligram of epinephrine is given.
Excellent. Epinephrine. So after 2 shocks, she has done the CPR for about 2 minutes. And then he says, oh my God, my shoulders are hurting. What do? Exchange. Be kind to the people, Be kind to our residents too. All right. And then after 2 epinephrine, you did the compressions. But Avinash is showing the same rhythm. It's continuing.
So I have already told them to plan for 300 milligrams of amiodarone to be loaded.
How much?
300 milligrams.
Correct. That is the cardiac arrest dose. And you will push it slowly?
No, it has to be given
Fast.
fast. And 20 mils of normal saline to be given.
Correct. Every time you inject a medication, obviously you have to follow it up with saline or whatever it is. What is your preference? Is it saline or Ringer's lactate?
Here we
Not here. What is your
we
preference?
prefer saline.
Saline. Saline is good. Ringer's lactate, there is nothing wrong. Except somebody will say, well, I'm pushing some electrolytes. That's okay. Saline is okay. How much of saline? Okay, I will come to that later. So, again, repetition. Patient comes with ventricular fibrillation. He's put on he was already on the monitor. And then the team is ready. They started compressions. Fibrillator is there. Defibrillator is there. They gave 2 shocks. In between, 2 minutes of high quality CPR. And she gave amiodarone. Again, as I mentioned, 2 shocks, 1 epinephrine, 3 shocks, and amiodarone. Now, it has been happening for 8 minutes. And we get restless. What's happening? 8 minutes.
And suddenly the monitor showed
Oh my God. Wait.
this sort
Wait.
of
What happened? What
a
is this?
flat line. Flat line is seen. So
Is it asystole?
Yeah, we have to get it confirmed by seeing the doing the flatline protocol.
Don't get nervous if it is asystole.
First, to determine whether it is asystole or not, you have to check the flatline protocol. So check all the leads properly, whether they are attached properly to the patient, and from the leads are properly placed and they are properly connected to the monitor, and increase the gain of the ECG also to check whether there is any fine VF is present or not.
Yes.
So you have to just get confirmed that the monitor which is showing flatline is absolute flatline, that is asystole. Once that is confirmed, then the treatment is CPR with chemical conversion. That's all.
So
immediately,
can I defibrillate this patient?
No, not at all.
Do not even talk. If you say defibrillation, asystole, you won't come back to medical school again. So it's important to, but make sure, as she said, sometimes it could be mechanical. Just the leads are off. Now this is a difficult rhythm. This is an extremely difficult rhythm. As I mentioned, I am relatively happy with ventricular fibrillation compared to asystole. Now, okay, so how long this has been going on? Dr. Radhika, are you planning to do anything else or you want to go home?
Sir, we are going to continue with CPR and load 1 milligram of epinephrine.
You don't need to do, just keep your hands here so that he is also doing. Okay, then.
And 2 minutes of CPR finished. Check the pulse.
See that?
Pulse is still.
Something is happening.
Pulse
There's some
is
blip.
not there.
I will tell you any kind of rhythm which will not produce pulse is a useless rhythm. So you don't depend on that. Okay.
So 1 milligram of epinephrine given and CPR is being continued, and because an advanced airway is placed, there is no 30:2 compression
I saw a
ventilation
rhythm.
ratio.
Can you defibrillate?
No.
No?
That's a CPR.
Don't
That's a CPR.
defibrillate unless it is a ventricular tachycardia or ventricular fibrillation.
You need to defibrillate only when it is ventricular fibrillation or VTAC without pulse. Ventricular tachycardia without pulse. That's all. Those are the only two rhythms.
It is 15 minutes.
15
What do you want to do next?
Continue CPR with
Continue CPR
with
until
1
your shift is
milligrams.
over. No. H's and T's.
So in the meantime, we just want to see any reversible causes are there or not. So 5 H's and 5 T's.
What is, can anybody tell, only just one person, anybody tell, now you have to see why this patient's rhythm is not being restored. Why?
Reversible cause.
So H's and T's. What are the H's? You can mention?
Hypoxia.
Phone channel. I mean, the microphone.
So, when after 30 minutes, even after 30 minutes, when there is 15 minutes to 20 minutes, when there is no resuscitation.
My question is very simple. What are the 5 H's?
Yeah, 5 H's and T's, we have to think about 5 H's and 5 T's always.
No.
One is
what are the 5 H's?
Yeah. Hydrogen ion concentration.
Hydrogen ion, that acidosis.
Acidosis, H.
H.
Hypoxia, hypovolemia, hypotension, hypothermia. Hypo and hyperkalemia. These are 5 H's and 5
Right?
H's.
Thank you.
Coming to
so we will explain everything. There is also what is called, I want to show you sinus rhythm now. Sinus rhythm. If there is a tachycardia, you can say sinus tachycardia. You don't feel the pulse. What is that condition called? You don't feel the pulse, but there is a rhythm.
That is pulseless electrical activity.
What is the condition we call clinical condition where you don't feel the pulse, but you see a rhythm? Could be sinus tach or normal sinus rhythm. What is it called?
pulseless.
Pulseless electrical
Pulseless
activity.
electrical.
Pulseless electrical activity. So here, this is the commonest thing. Sinus tachycardia is very common rhythm for pulseless electrical activity. And the common cause of pulseless electrical activity is what?
Hypovolemia.
Diarrhea, dehydration. Hypovolemia. Common, very common.
Very more.
So here, there is total dissociation of excuse me? Absolutely. The rhythm is being generated, but it's not felt. Total disruption of the cardiac impulse as well as the pulse. It's not propelling enough energy. So then you have to think about these H's and T's. Now, what are the T's? Instantly, before I leave H's, hyperkalemia, especially if you have a cardiac arrest in the operating room, especially in children, it is most common, most probably it is hyperkalemia. Okay. Hyperkalemia. No, that's okay. Let's keep on going. How do you manage hyperkalemia? What is hyperkalemia definition? What is the definition of hyperkalemia? I'm talking about acute hyperkalemia.
Amita.
The levels of potassium levels in blood.
Yes. Hello? No. You have to be specific when I ask you a question. What is the number you give? 5.5, 5.8, 5.6?
5.
So, anybody at
More
than 5, you will just go ahead and push the medications? Again, the answer is, it depends. If you have a cardiac patient, if you have a kidney patient, they're used to hyperkalemia. And if you have a normal person, and if the potassium is like 5.9 or 5.6, then you should be concerned about. So, how do you manage hyperkalemia? Let them answer, because how do you manage hyperkalemia?
Hyperkalemia, there will be high prone for arrhythmias, cardiac arrhythmias, for stabilization of the
How do you manage hyperkalemia? 1, 2, 3, 4.
Insulin, potassium binders, calcium gluconate, potassium binders, insulin, along with insulin, with dextrose, IV solutions, astalin, salbutamol in nebulizations.
Wonderful. If you are in the operating room, the easiest thing for you to do is to hyperventilate the patient. So all that, when we say hyperkalemia or hypokalemia, we are relatively talking about the total amount of potassium is more or less the same. It's the amount of extracellular potassium that you're talking about that is producing the clinical effects. Okay? So your idea is to push back the extracellular potassium into the cells, and that's the whole thing. So if you can hyperventilate the patient, especially in the operating room, there's a cardiac arrest, hyperkalemia. But again, you have to be very careful. When you send the sample to a lab, most probably she needs to know how much of medication is given, what is given, so she or he may not remember. So everybody is very important here. So let us do this. we'll create a scenario. Avinash? Okay. And Dr. Radhika, you handle the scenario. This is your team. You can have any number of people there, persons there, and then so. Okay, you're ready? You're ready? And I want to bring first one of you. Some of you, from there after this batch. Feel free to come. So what do you want? I will do it. All right. Here is a chronic hypertensive patient, and he is on diuretics, and he takes a bunch of medications. He's about 75, and he forgets. And his wife brought him to the emergency room here. She doesn't know what kind of medications he takes. He is a insulin-dependent diabetic. His hemoglobin A1C is about 9.5. So practically, so he was brought to the emergency room here with acute shortness of breath, and he's coughing a lot. That's the scenario we are creating, and he goes to the emergency room here, and Dr. Radhika, he puts him on the monitor because she's not happy with how he is presenting himself. Shortness of breath, 70 plus, insulin dependent diabetic, and he is not able to express, properly or appropriately the questions. Okay, let's do it. 1:30. He's talking to you. He is not upturned, he's talking to you. Dr. Radhika, so here is the patient. He comes with some rhythm.
So, patient, what's the blood pressure? What are the vitals?
The blood pressure is 180 over 100. Saturation is 91. That's all I can give.
So, what's the blood sugar?
Blood sugar, good question.
So, CBG?
320.
320.
Consult with your team.
How is the patient? Conscious?
Whatever you are discussing, they should be able to
Patient
hear.
is conscious. Please check the consciousness. Patient is irritable. Confused. Then
So this is the
monitor
team
is
approach.
showing.
This is not cardiac arrest yet.
This is not
So
cardiac arrest.
they are able to consult among themselves. And Radhika is also consulting. He's teaching.
SOP.
Residents and all that.
So take care of the airway immediately. Put oxygenation. Give oxygenation. Saturation is 988. Give oxygenation. High flow, 10 liters of oxygen.
Okay.
And
this is
then
what you should do.
Blood pressure is
When you
180 by
say-
90.
What are the clinical characteristics?
Tachycardia.
What kind of rhythm is that?
It's sinus tachycardia.
Sinus tachycardia.
Yes. It is
Atrial fibrillation.
fibrillation.
That's okay. Don't worry. Don't bite your tongue. Atrial fibrillation. The rhythm. Atrial fibrillation. Is he hypoxic? Is he hypoxic? Is he hypoxic?
Yes, he's hypoxic, sir.
Okay.
He's
Atrial
hypoxic.
fibrillation, hypoxia, and hyperglycemia. That's all. Okay. Hypertension.
How are the lungs?
So that's how you have to.
How are the lungs?
All right. Now you are talking to him, and I gave you all the lab reports. What do you want to do now?
Immediately
Don't
start.
go
hypertensive-
into the defibrillator for
No,
every
no,
patient.
no. Antihypertensive drugs should be started.
Patient is
Patient
probably
is
on
in pulmonary edema.
You examine
Yes.
And yes, there are a lot of
Lungs
RAS.
are full of crepes.
It could be
Bilateral.
secretions too, you know. Elderly people, they can't clear the secretions and they could be misinterpreted as crepitations and all that, you know. So what do you do then? Forget now this. I will put it like this. Avinash, next 2 minutes we are going to discuss. You put it like this. Okay, what do? You diagnose things. Again, repetition.
We'll put on
Hypoxia,
Hypoxia.
Hypoxia.
atrial fibrillation, hyperglycemia,
And
pulmonary edema.
hypertension.
Temperature is, you're all centigrade, right? 34.
And 180 by 90 is
Hypothermia. Now forget about it. How do you approach
How
this
can
patient?
you-
What do you do? Call the cardiologist.
We'll put oxygen.
We'll put oxygen.
You put how much
and
of
then
oxygen you put?
I'll
We'll
give
start with 5 liters.
What? In the
Face
mask?
Yeah,
Mask?
face mask.
Why face mask? You don't like nasal cannula?
Okay, we'll start with nasal pumps.
No.
2 to 4 liters nasal
will
pump.
not be sufficient.
But our
Why do you
saturation-
want face mask? I'm asking a question.
Our goal of saturation is 90.
You should know when to use nasal cannula. You go and read today. Okay? If I were you,
Saturation is about 94. It should be at least 94%.
correct. So if you don't have to put the mask, right?
Yeah.
You first
We can
accomplish
start with nasal cannula.
how much? How many liters?
But then
2 to 4
having
liters.
gills.
Excellent. So what else you do, Radhika? How do you manage this? Is this a lethal rhythm?
Yes, we'll start amiodarone, sir, for this patient, or rate limiting agents, any rate limiting agents.
What she's trying to tell you is, you have plenty of time. You can call the medical consultant or you're taking care of it.
No, we'll take care of the rate limiting agents. We have to first take care of the atrial fibrillation.
How do you
And-
acutely manage atrial fibrillation?
Atrial
Is it
fibrillation-
life-threatening? People live for 100 years with atrial
Yes,
fibrillation.
it's not life-threatening.
And you know what I'm saying?
Yes.
And so, is it life-threatening?
It's
So
not
you
so
got some
life-threatening.
breathing time.
Yes.
I just want to tell you, not everybody coming to the emergency room needs cardioversion or defibrillation. So we have to use our common sense. There may be simple things. This is just an example. Now, we are going to have a full-blown cardiac arrest session, and I will tell you, Dr. Radhika, you create a scenario, you go with Avinash, and then both of you create the scenarios, and you should be able to do it. Again, I need the RASC in 13 minutes, not 15, not 20. Dr. Radhika, you're on. You take care of it, you go work with Avinash here. Okay, one of you take this. Who is the leader here? Yeah.
Can I be the same leader?
So again, this is the teamwork. And I'm going very slowly today because I want you to understand the concept. So in the next 10 minutes, we are going to terminate, and I'm going to take you to the artificial intelligence thing, and I will ask the faculty members and the senior residents, only faculty members and senior residents to come, because that is, that is pretty intense. Okay? Go ahead. All right, Dr. Radhika. So these are the pearls, you have to remember. When you face a patient, use your clinical assessment quickly. And if you want to do any kind of, management, the first impression is always, unfortunately, we as physicians have a tendency to have some fixation in the mind. Somebody comes with chest pain, oh my God, that's it. This guy is having heart attack. Not knowing he has eaten a lot of masala stuff, and that's why, he is having some kind of retrogastric pain. So it's important, so we should not be biased. Unfortunately, majority of the physicians, we have a tendency to prefix the diagnosis. And that is a big problem with all of us. So we have to come out of that shell and make sure that we keep our, ideas out of the shell. We have to think everything. I'm not talking about the rare things we will never present, to you. So, Dr. Avinash, we don't have a lot of time. Go ahead. I'm more interested to see the module, the next artificial intelligence module. You are going to love it. I'm telling you, the first time I introduced here in Hyderabad, that was last year. Usually, we reserve that type of teaching modality for the faculty, but it's kind of, it's a very, very important, kind of knowledge that you will also be imbibing, Go ahead, please. We don't have a lot of time. Okay. So, unfortunately, we don't have a lot of time for the questions and answers, but you've got a very good team of experts here. And how many of you have passed basic life support? BLS. It doesn't matter, whatever the organization. How many have passed the basic life support certified? How many of you are certified in ACLS, Advanced Cardiac Life Support? How many of you passed, the PALS, the Pediatric Advanced Life Support? I want all of you to pass BLS and ACLS. And of course, for pediatric postgraduates and all that, I think it is important to have the PALS. We have several excellent teams in India, to advance with the simulation technology. And I just did a module in Hyderabad last week with one organization for the pediatric resuscitation. It was excellent with the interaction with the participants. Okay, please. Are you ready? Dr. Radhika, you got only 10 minutes. After that, we'll terminate, and I have to go for
So here is a renal patient who is already CKD patient, who is on hemodialysis, maintenance hemodialysis, has come to emergency room with SOB.
I'm going as a first responder. 1 minute. Hello, sir. How are you? What is your issue?
1 minute. Patient first talking. So, okay. Yeah. Sorry, me too.
You got 7 minutes. Yes. Put a hold. You can make an announcement. You do it tomorrow, no? Yes, sir. I know, that's why you see you don't do it. We'll finish off. Yeah. Whatever. Yeah. You ask the permission of the principal.
Sir, one scenario of 5 minutes, then we'll start the inaugural, sir. Is it okay, sir? Right. So this is a 65-year-old male who is a renal failure patient who is on maintenance hemodialysis, has come to emergency room with shortness of breath.
I'm the first responder, going to the patient. Hello, sir. How are you? What's your complaint?
Patient is conscious.
Conscious. As the patient is having shortness of breath, we will take to the red priority. Please connect the patient to the monitor. Dr. Amrita. Please someone check the BP, pulse oximeter. So by seeing the monitor, it's VT. Hello? Hello, sir?
Yeah, he suddenly collapsed.
Collapsed.
He became unconscious.
Checking for the pulse.
Pulse is not present.
Pulse is not present. Dr. Harideep, please
It's
start
VT.
CPR.
It's VT.
Meanwhile, Dr. Shanmugam, connect the monitor, defibrillator, charge it for 200 joules and give a shock. Meanwhile, continue CPR. Dr. Hema, take care of the airway. Charge, is it charge? Go, give.
Please be clear.
All clear. Giving the shock 200 joules.
Continue CPR. Dr. Venkatesh, please record the timings, starting from the shock.
One of you secure the IV line.
IV can't be secured. So go ahead with intraosseous.
So, CKD patient, most likely cause can be due to hyperkalemia, one thing, and he might be in pulmonary edema, shortness of breath, can be hypoxic arrest also. What is the timer? Check the leads once.
You know, it's most important, you know, every second counts. So if you are doing it, you just put your hands here, you know. I mean, you can have, there is no conversation. Just, you know, whatever you like, whatever you say.
Suddenly the monitor showed this.
Check the leads, the monitor. It's only systole. Continue CPR. Dr. Amita, give 1 mg adrenaline IV start, followed by 10 ml bolus NS.
Two minutes of CPR over.
Check for the pulse, assessing rhythm, still asystole, continue CPR. So what can be the cause of this patient to get arrested? Kalemia. So we will start with calcium gluconate, load calcium gluconate 10 ml.
Calcium gluconate 1 gram.
Give 10 ml.
10 ml over 10 minutes. Slow IV.
Starting insulin dextrose.
2 minutes of CPR.
2 minutes of CPR. Okay, done. Check for the rhythm.
Pulse
The
is present.
Pulse is present. Rhythm is there. Secure the airway.
Post cardiac arrest, what do you want to do with this patient?
We'll see for the BP, ma'am. We'll check the BP. We'll check the
So
saturation.
what do you want to take care of?
Airway, breathing, circulation.
So don't you want to put the patient on target temperature management?
ABC, ECG, then
Yes.
TTM.
TTM. At
TTM,
what, how much time and at what temperature?
32 degrees for 24 hours.
32 to 36 degrees centigrade for
24 hours.
Yes.
They are trying to do a good job. This is not a perfect ACLS, but they are trying to do their best, because that's how you have to learn. So what was the first rhythm that was there? He presented with ventricular fibrillation, right? So what did you do immediately? What did you do immediately? You started the CPR and you got the defibrillator, and then you gave compressions, 30 compressions and 2 breaths. And then after 2 minutes, you defibrillated. Okay, that's number 1. And after that, you did the CPR for 2 minutes. And then any kind of intervention, you must do the CPR, high quality CPR for 2 minutes. Okay, that's important. So 1 shock, 2 minutes of CPR, second shock. How many joules you have given? You are using 200. This is bipolar. I'm sorry, biphasic. What is the difference between, you are not using any monophasic, right? Good. So biphasic has the potential of giving more energy at a lesser electricity, you know, and it is A to B, B to A. Okay? So 2 shocks, and then what did you do? CPR, and then did you give epinephrine? Epinephrine, and then nothing happened, right? CPR, then defibrillate. So you have to do drug shock, drug shock, drug shock. But once you are given 2 doses of epinephrine and 3 times shock, then you give amiodarone. So the dose is 300 milligrams fast. You can also repeat. How much? 150 milligrams. Okay, because this amiodarone is a multimodal, type of pharmacological agent. It affects almost each and every aspect of the cardiac cycle. Okay, and then of course, have you checked the HS and Ts? 5 HS and Ts, because if there is any potential reversible cause, That's where you have to be aggressive, after a certain time, like maybe 10 minutes or maybe 5 minutes. It depends upon how you feel about the situation. So I think ultimately you got the sinus rhythm, and most of these people are hypotensive, so you can give about 5. If there's no past history of kidney disease or anything, congestive heart failure, feel free to give about 500 cc's of, you said normal saline, right? Normal saline, and then make sure, see, can you draw electrolytes during cardiac arrest? Never. Never draw. It's a mistake. You always get the bad, it doesn't make any sense. Unless you have the circulation, do not. If there is hyperkalemia, it will have obviously bad results, so we should never attempt at all, So after that, yes, the patient is not recovering mentally, so you did the hypothermia. And then after hypothermia you must do for any patient who is unconscious and has recovered the spontaneous circulation. Okay? It is mandatory now, in most of the circles of resuscitation people. Then you do for 24 hours of 32 to 36 degrees centigrade. And then you can pick up, and once you pick up a fixed temperature like 33 you fixed, keep on continuing it, don't change it. You should never change 32 at 8 o'clock and 34 at 10 o'clock. Whatever that you have chosen, you be consistent and do for 24 hours minimum. And then we call slow rewarming for the next 8 to 12 hours. And of course, you also have to make sure that you got an efficient team tracking down the electrolytes, because these people may go into hypokalemia or hyperkalemia, calcium problems and all that. So a big round of applause to this great team. Thank you.
Thank you, one and all. We'll just start the inaugural.
You will be doing, in a very, very rational way. Simply because you got a lot of gadgets doesn't mean that you have to use all the gadgets. As I said, if you have a patient with headache, you don't say, no, I will do the CT scan of the head. Okay, so this is I really would like to spend at least an hour on that after the inauguration. Thank you, Dr. Radhika.
Thank you very much, sir. We'll start the inaugural function. I would like to call upon Dr. Sundarachari sir, the chairman of this, organizing chairman of the Global Advances in Emergency Medical Care. First time we are doing the emergency medicine conference after the establishment of Department of Emergency Medicine. Thank you very much, sir, for giving us the opportunity to do this program. And I would like to call upon Dr. Yashashvi Ramana sir, co-chairman of this conference, onto the stage. Medical Superintendent of Guntur Medical College and Government General Hospital. I would like to call upon Dr. Subbarayudu Garu, IMA President, Guntur. And I would like to call upon Dr. Balbhaskar Garu, Gymkhana Coordinator. And I would like to call Dr. Vemuri S. Murthy Garu, who is the Program Director, invited US faculty of this conference, as well as the chief guest of today's program. Thank you very much, sir. I would like Sundarachari sir, who is the presiding officer for this program, to preside the meeting. So you just I would like Sundarachari sir to say a few words regarding the conference. Lightning of the lamp, sir. Sir, lighting of the lamp.
Sir, please. Oh, సాయంత్రం అయితే లైటింగ్ సంజ దీపమా
A small prayer song. వినాయక నీ మూర్తికే నా మొదటి ప్రణామం. నీవు కొలువున్న మా మనసే నిరతము ఆనందధామం. వినాయక నీ మూర్తికే శతకోటి ప్రణామం. లక్ష్మీరమణుడు శ్రీహరి కూడా తలచును నీ శుభనామం. వాణి బ్రహ్మ ఓరిమి చూడ చేతురు నీ గుణగానం. పార్వతీదేవి హృదయ విహారీ, పార్వతీదేవి హృదయ విహారీ శివస్తుతి గణనాథ. వినాయక నీ మూర్తికే నా మొదటి ప్రణామం. నీవు కొలువున్న మా మనసే నిరతము ఆనందధామం. వినాయక నీ మూర్తికే శతకోటి ప్రణామం. శతకోటి ప్రణామం. శతకోటి ప్రణామం. థ్యాంక్ యూ. I would like Sundarachari sir. I am ever first. Yashashvi Ramana sir. Okay sir. I would like Yashashvi Ramana sir to say a few words.
Hello. Good evening, my dear students and dearest faculty and the dignitaries on the dais. The cynosure of this today's function, Professor Murthy Garu and our beloved Principal Dr. Sundarachari Garu and Subbarayadu Garu, our faculty today. A good evening to all of you. I am very much delighted to be here, to be associated with this great academic feast. 1 minute. Hello. సార్ మెడికల్ కాలేజ్లో సార్ హలో మెడికల్ కాలేజ్ ఫంక్షన్ వెళ్తున్నాను సార్ చెప్పండి సార్. అవును సార్ అంతకుముందు మనం అవును సార్ అవునవును చాంబర్ దగ్గరకు అరగంటలో రమ్మని చెప్పండి సార్. నేను మెడికల్ కాలేజ్ వెళ్ళినా చెప్తాను సార్. మీ పేరు ఇవ్వండి డాక్టర్ సారీ. సో very much useful program to the students, especially of your age group, wherein you need to be a very fruitful and successful and responsible doctors in the society as you evolve into your adulthood. So CPR is a basic thing which you need to learn, everybody need to learn to save the lives, especially when the situations are really unwarranted, such things will happen. So wherein you need to be geared up to rise to the occasion and to save the patient life. So this simple, it appears to be simple, but you see a day long, so much of patience with a lot of commitment. Dr. Murthy has done this. Please give a big round of applause for his patience and for his commitment to come all the way from USA to teach students of his alma mater. Really, it's not a small thing. Unless you have a big heart, you will never be able to do this, because forever, for anybody in this fast era, time is money. So, but keeping aside all the things, he has come here to teach you all. So I think you have learnt it to the core, and you are going to be useful to the society, especially a country like this with vast country and with big population. So we need to have so many like you who learnt this technique in the society. So this is what you have done. So I thank you all for being associated with this particular day-long session of saving the lives in the form of CPR. So I think you must be knowing by this time the lot of intricacies involved in this particular program. So there is a mannequin, everything they have really taught in a scientific way. So that way you are really very much, I think you are fortunate enough, because for such courses you need to go long distances by paying a lot of registration fee and accommodation over there. So such things have not happened. Pleasantly have come here and happily learnt everything that Professor Murthy Garu and the other faculty members told you. So with these few lines, I just thought of wishing you a bright future, and wherever you go, you should spread smiles across smiles as a young generation in our country. So I immensely thank from the bottom of my heart Professor Murthy Garu for making you learn things in such a nice way. So I heard about him a lot, and I have gone through his profile. Such a great personality who is with us to serve his alma mater, to give back to the society. That is his concept. So we should always be thankful to him and grateful to him. And thank you very much, sir, once again. And Radhika, thank you for taking such a great pain in taking up this particular course, because nowadays taking up a course like this single-handedly with little small department is not that easy. So you have taken a lot of interest in this. Thank you, and thank you for giving me this opportunity. Thank you all.
Thank you for all. Thank you very much, sir. You are giving us a lot of support, and both morally and also in terms of staff and area and all that, sir. After you came, we are really happy organizing even the red, yellow and green zones and all that. Thank you very much, sir. I would like Dr. Ayudu Garu to speak a few words.
Thank you, Radhika. Good evening to you all on the dais and off the dais and dear students. Initially, Radhika told about this emergency workshop. I thought that is not belongs to my specialty. Basically, I am an ENT surgeon. But before coming over here, luckily I have seen that YouTube link. I have gone through some of the program. Sir clearly mentioned about the advancing technology and also before the Code Blue rapid response team and also the technology. Before arriving the ambulance, drone driver AED. Really, those are amazing to know that. And also, sir mentioned so many things. Those are all very much useful for my day-to-day practice also. I missed the program. Sorry for that because this is a Monday. Today is a busy day. That's why. And also, sir also told that think globally and act locally. In the same way, I'm requesting, sir, the global technology transfer to the please this local area by way of technology and also the instruments. Luckily, we are also almighty of this medical college. I'm requesting that and also congratulations for all these participants for the good conduction and also the Radhika and helping the dynamic superintendent principals always with us to provide all this type of educational activities. Thank you. Thank you so much.
Thank you, Andy. I would like Principal Sir to speak few words.
Good evening, all of you. Distinguished guest of today's CME, Dr. Vemuri Murthy Garu, our beloved Superintendent SSV Ramana Garu, and Senior ENT Surgeon Subbarayudu Garu, and the organizing secretary of today's CME, Dr. Radhika, and his department, her department. We are conducting resuscitation, hands-only CPR on adults. I did my MBBS from this college. During my MBBS, my PG, my favorite PG in orthopedics, Dr. Daniel, had cardiac arrest while I was doing duty, night duty. At the time, the Department of Cardiology was there, but there were no facilities. All the physicians on that day came in rescue and they have resuscitated by pressing over the chest. He recovered. He survived for 10 years. After that, he moved to Saudi Arabia. There he had another cardiac arrest. Though he recovered, he sustained multiple fractures of the ribs. After my MD Pediatrics from Andhra Medical College, I was working in a community health center, Chodavaram. One infant was brought to me. That infant was declared dead. By the time I examined, luckily I was there on that day. I was doing my duty from Visakhapatnam to Chodavaram. It takes 1 hour. To his luck, I was a pediatrician at that time. I have given him mouth breathing without any hesitation. He recovered. He is named after my name. He is still there in Chodavaram. That child was named after me because of me, parents thought has recovered. And another incident in Visakhapatnam, I did my MD Pediatrics from Andhra Medical College, DM Neurology from Usmania Medical College. My favorite surgeon, Professor of Surgery, Veerabhadra Garu, senior most surgeon, he worked here also as superintendent. He used to come by cycle. Then he was transferred to KGH. He used to go to KGH by cycle only. He had cardiac arrest while driving a car to his flat. Bystander going on that street found that incident, he was collapsed. And without knowledge, that illiterate bystander pressed over his chest, he has recovered. Still he is alive in Visakhapatnam, Dr. A. Veerabhadra garu. 2 years ago, I went and saw him. So what I want to say is, by mouth-to-mouth breathing, by rapid compressions of the chest, they have recovered. It is found that around 4.5 to 5 lakhs of people across the globe are suffering sudden cardiac arrest, either at home or in the workplace. Not 1 lakh, 4.5 to 5 lakhs are suffer cardiac arrest due to many causes. It is also found that 5 out of 10 of those individuals who suffered cardiac arrest were revived by the primitive CPR done by the bystanders. That means CPR is life-saving. The person who is doing CPR is nothing but God. I have not seen God, but that is a godly process. Giving rebirth. But things have changed. Technology have changed. Lot of advancements have happened across the globe. An example for that, Dr. Vemuru Murthy garu. Without any harm to the patient, without causing fractures of the ribs, without letting him go into complications like hypoxia, they are recovering without any sequelae of hypoxic ischemic encephalopathy. Time is very important. So today's session on adult resuscitation is very useful. I thought of attending, I could not. Sorry for that. And I think I have enjoyed the hands-on CPR today. Very useful. Everyone, not only the medical personnel, not only nursing people, even the educated, illiterates also should learn how to do the basic CPR. So what I want to convey again is, it is very, very common. See, 5 lakhs in a year is very high, sir. And the chances of recovering from cardiac arrest is 3 to 4 times after resuscitation. So there lies the importance of CPR. Thank you so much. I think I have understood the importance of my examples, my live examples of encountering such people. Thank you very much.
Thank you very much, sir, for your good speech, encouraging words. Now I would like to ask Dr. Vemuru Murthy, sir, to give a few words, speak a few words. Yeah, you can speak.
What a great day. Having graduated from this wonderful alma mater of mine, I feel the energy. I graduated in 1974, having joined in 68. I feel the energy today. I feel as if I am the first year medical student. We get the energy from the younger generation. That's what we are for. We can guide you, but you are the ones who have to take the mantle. You have to take the energy to make the country move further and further into the great, bigger picture of international collaborations and international healthcare projects. I'm very proud of you. Our Honorable Dr. Sundaracharya Garu, Dr. Ramana Garu, Dr. Subbarao Garu, you know, today is a great blessing for me. Again, as I said, I come to India a few times in a year, but going to your own alma mater and being able to interact, being able to feel the same kind of energy that we used to have in 1968 means a lot to me personally. Thank you. Again, as I mentioned, resuscitation medicine is in infancy throughout the world. You really want to make sure that you use all the resources available here in Guntur, in India and everywhere, so that you will become one of the clinical experts par excellence, so that we can at least contain majority of the problems that arise as a result of the number one, the killer, human killer, that is the cardiac disease. And I am really thankful to Dr. Radhika, whom the American Heart Association, we trained almost like 15 years ago, and she is really so energetic. I have not seen any much change in the amount of energy she had. I will tell you, it's very simple. You work hard for any kind of destination, and there is so much of the wealth of research in India that I'm really, really proud that my initial medical education happened in India, and that too from this big, great institution. Thanks again, and from the bottom of my heart, I thank you very much, and especially Indian Medical Association. I'm very grateful. I've been, I think, associated with it only for 5 years, and thanks to them, now we have an oration that they created, thanks to you, for the most distinguished person who has contributed significantly to the advancement of cardiac health. And I thank the the Indian Medical Association, for putting an oration in my name. Thanks again. God bless you. Don't leave, because the most exciting part of the artificial intelligence is coming up, and I am hoping that you will enjoy this much more than what you have seen previously. Thank you.
Thank you very much, sir. We would like to felicitate, sir. Yes, sir. I invite Principal sir and Superintendent sir and IMA President Dr. Rayudu Garu to felicitate Dr. Vemuru Murthy sir. Sir, please, sir. Please, sir. Sir, small felicitation to all three of you, sir. Please. Sir. Sundarachari, sir.
కాకపోతే అసలు ఇంకా మీనింగే లేదు ఇప్పుడు ఈ ప్రోగ్రామ్ మీనింగే ఉండదు నిన్ను ఫెలిసిటేట్ చేయకపోతే
She's the centerpiece. ఎట్లా యూఎస్ నుంచి చాలా ఈజీగా రావచ్చు. సార్ రమ్మని చెప్పండి. సార్ మీరు ఉండాలి సార్.
మూర్తి సార్, మూర్తి సార్. డాక్టర్ హరిదీప్, Dr. Haridip, sir, Ramana sir, AIMS Assistant Professor sir, AIMS Mangalgiri. Thank you very much, sir. And I thank Gymkhana organization who supported this program. And I thank Dr. Ram Koteshwar Garu, who is the current president of Gymkhana. And I thank IMA Guntur. And I am extremely thankful to Sundarachari sir and Ramana sir. As soon as I told about this program and Murthy sir contacted me, Sundarachari sir has immediately responded, and because of him only this program has been organized in such a short notice. It is so short, it's just a weekdays ago. On 21st there is nothing, and on 27th there is everything. It is like that, such a short notice, and I thank all the participants who have come and participated in this program, because 500, 600 registrations in such a short notice is not an easy job. I thank all of you and all the organizations, Vignan and Chalapati College of Pharmacy, Vignan College of Pharmacy, and our School of Nursing, and our Government College of Nursing, and my teachers, and our postgraduates of Guntur Medical College, and our faculty of Guntur Medical College, and also all the IMA members. I thank each and everyone who supported this program, even if it is such a short notice, just a weekdays. Thank you very much. If I miss someone, please don't take it otherwise. Lot of stress in just 2-3 days. I traveled Vizag and came back. My daughter is not keeping with good health. So many things. Ante mix and match of everything ante ilage untundemo. Multitasking ante. As an emergency physician, we are used to being a multitaskers, but sometimes it will be too much to take. And I thank the print and paper media and electronic media, because of whom the news has gone so fast within one day. I thank each and everyone, especially from the bottom of my heart, my Gymkhana association, because but for them, today's program would have been a big chaos. Thank you very much. Thank you, sir. And we will break for tea for 15 minutes, tea and snack, and we'll get back here in 15 minutes by 5 o'clock. Is it okay, sir? Or we'll finish off and then break for tea? Because everything is arranged outside. Okay, we'll continue the program, but in the meantime, tea and snacks are arranged in the dining area. If anyone, please go and have. Okay? Thank you. This session is very, very important. It is completely artificial intelligence into resuscitation. I would like all of you to please sit down, no? Just 15-20 minutes, the session will be over.
Thank you. I want all of you to come to the front, you know. This is a real experience for you, just like three-dimensional experience you have. Please come to the front. Can we have all these lights off, Amma? Can we turn off all these lights that they can see them? Can you see? I got so many cases, you know, of almost every specialty. But today we are dealing with emergency medicine. So I'm going to show some of these cases, at least a couple of cases, and you will have also the interaction with us. I'm loading the case. Can you all see? This is a 47-year-old male with chest pain after running this AM. The triage ECG, no ST segment elevation, no cough, no fever. So, here is the thing, you know, we can interact with the patient. You can do anything you want with the patient. And we have got a variety of modules, but I'm going to choose this one. So, now this is the patient. His name is Julian Dixon. He's 47 years, and he weighs about 78 kilograms, and his code status is full code. That means you really have to work hard if he goes into the code. Now, I'm talking to the patient. Hello? You can type faster. Faster, okay. I'm saying hello to him, okay? See the response. He says, hi there. I think we need the audio. Okay. I would say, how are you doing? He says, I'm experiencing some chest pain today. Okay? So, What do you do first? You have to put him on the monitor, right? He is with you in the emergency room. And is there anything else you would like to ask? Since when you have the chest pain? I am going to ask.
Dr. Federowicz, please report flat, balloon pump. Dr. Federowicz, balloon pump.
Okay. He says, I started having the chest pain about 8 hours ago. So what do you do? This patient is 47-year-old, a relatively healthy guy, healthy looking guy, and he comes with the chest pain. What is the first thing you do? You put the monitors on, right? So I'm going to go and look at the monitors. So first you stabilize, but before that you attach a monitor. I attach the monitor. See what happens. I'm going to put him on an EKG monitor.
Please report flat, balloon pump. Dr. Federowicz, balloon pump.
I don't see the monitor, so let me go to another module. There is a problem with this module, so I'm going to get another module. Just bear with me, just for a second. Okay, getting there. So I'm putting all the cases, and now we're going to go to a case with, which one do you want? Chest pain at rest? Okay. Hopefully you'll get the monitors and everything back on. Okay, this is a 57-year-old with chest pain for the past 1 hour. Described as intermittent, now rated 4 out of 10. Looks ashen. The triage EKG done, pending review. I'm beginning it. So here is the patient, and he is in the emergency room here, and he came to you, and you can ask him any questions. What questions you would like to ask? This patient comes with chest pain. What is the first question you ask? He looks okay. What is the first question you want to ask? Bring another microphone. You can answer. I will type. Whatever you want to say, you say. Bring another microphone. A patient comes to the emergency room with a chest pain. Dr. Radhika will ask the question. Talk to the patient.
Code blue, hospital lobby. Code blue, hospital lobby.
There is already another code blue going on. I attached a monitor.
Yes.
No, you don't need that. You don't need to go. Come here. So you put the patient on the monitor before you ask the questions, okay? So what does it show? The blood pressure of 142/75 and a saturation of 99. Would you like to ask the patient any questions?
I will ask for the symptoms, chief complaint.
Main complaint we all know is chest pain. Yeah.
So from when the chest pain is having, what is the quality of the chest pain?
Okay. So we'll ask any previous history of high blood pressure, previous medical problems. Let me see. I'm going to type previous medical problems. The answer is, I don't have any previous medical problem. 57-year-old, he comes with chest pain. What else would you like to ask?
I would like to ask any additional symptoms like sweating, vomitings.
Okay. Vomiting. Let's say vomiting. I am feeling nauseated, but I have not vomited yet.
Sweating, sweating.
You have to take quick questionnaire, I mean, he said, I'm sweating for no reason.
Palpitations.
Well, he doesn't know what is palpitation. Thumping of the chest
Thumping of the
is
chest.
there. Okay, so he obviously has some problems. Now, you look at the team. What kind of exam you are going to have?
I'm going to perform circulatory system.
You first look at the assessment, okay? The blood pressure is normal, heart rate is normal, saturation is 100%. So, and he has a chest pain, and you want to examine which one?
Circulatory system.
Circulation exam, okay? It says 2 plus peripheral pulses, normal capillary refill. Anything else?
Cardiovascular exam.
Cardiovascular exam, regular rate, rhythm, no murmurs, no rubs, no gallops. You can see it's perfect. So what's happening?
I'm suspecting acute coronary syndrome.
No, don't say anything. You already examined. Anything else you want to? Pulmonary exam?
Pulmonary exam.
Pulmonary exam, clear to auscultation bilaterally. You want abdominal exam?
Yes, I'll perform.
Okay. Why do you need the abdominal exam? This is normal. Abdominal exam is normal. Okay, now you have to stabilize him. That means you should start an IV. What kind of IV, what kind of fluids do you need?
Normal saline I'll start.
Okay, normal saline you started. And what else you would like to do? 98. What are the bedside tests you would like to do?
I would like to have a 12 lead ECG.
12 lead EKG, excellent. So we go to the imaging and then do the EKG on the top. Yeah, EKG, yeah. EKG is done. Perform. Can anybody see what is there in EKG? So this is the EKG. I want him to interpret that for me.
So normal rhythm, normal.
This is, we are creating a scenario of emergency room here with a lot of disturbance and all that. Okay. Can anybody describe this? A cardiologist or anybody? Dr. Radhika? We have to quickly interpret that. Is there any ST segment elevation, depression or anything?
ST segment depression is there in lead V2, V3, V4, V5.
So there is ischemia. You call it as ischemia. Any left ventricular hypertrophy?
No sir, not.
Okay. Fantastic. And what do you do then? What are the bedside sets you do?
I'll ask
Lab
for
work.
troponins.
Right, go right away to troponin. Okay.
Patients.
All right. We are doing the troponin test. Troponin is 0.09 microgram per ml.
Not likely, but it's it can be an acute. Still, it's.
So any kind of lab work, any CBC or anything? Arterial blood gas. Do you need arterial blood gas?
No, sir.
Okay. Anything else? Do you need anything? Troponin completed. What else would you like? You want a chest X-ray?
Chest X-ray is needed.
Okay, chest X-ray is done. Okay. Perform. What does it show?
Normal. Looking normal.
Chest X-ray is normal. So this is how we create, whatever you want to do, whatever you want to, however you want to diagnose, you want some help. Would you like to call a cardiologist at this point? He's having. No? Okay, let's say you consult a cardiologist. The cardiologist is very concerned about the EKG and is able to take the patient to the catheterization lab as soon as you are ready. What do you do then? Are you want to give some medications, nitro or anything?
We'll give antiplatelets.
No. I mean, but he's having chest pain.
Chest pains.
According to our guidelines, how do you manage chest pain? Give morphine?
We'll give nitroglycerins.
Nitroglycerin. How much of nitroglycerin? Let's see.
5 mg sublingual.
So the medications, you have to stabilize, right?
Stabilize.
In the stabilization, you have intubation, the drugs, and let's say intervention. Medications, which one do you want? Cardiac medication?
Cardiac medications.
Okay. You want to give amiodarone, aspirin?
Aspirin I want to give.
Okay, you gave aspirin.
Atorvastatin.
You have to do one thing at a time. You gave aspirin.
Atorvastatins.
Atorvastatin you gave.
Clopidogrel.
Oh my God, you are pumping a lot of medications into him, simply because they've got access. Okay. Anything else?
We'll give heparin.
You have to watch what's happening to the EKG. It came down to from 90 to 82. Now, So let's go on quickly go through the, you stabilize the patient, you grade it, and the different, what is the differential diagnosis? Cardiovascular? What do you think it is? Acute MI?
Acute
Ischemia?
MS. First diagnosis is acute.
How do you diagnose acute MI? There is no ST segment elevation, right?
NSTEM is sir. Non-ST segment elevation.
Non-ST segment
elevation.
elevation with ischemia?
With ischemia.
All right, I listen to you, I hear you. So your diagnosis is myocardial infarction. Remove anything else. I'm going very fast. He diagnosed differential diagnosis myocardial infarction. We already removed that. Anything else? Neurological, ophthalmological,
No, sir.
toxicological. Okay. So let us. Then what do you do next? Communication. The cardiologist already said, send the patient to the cath lab. So then you write it off. That means in hands off. We call hands off. So admit to the floor, transfer to the
Transfer
cardiac
to CC.
catheterization lab, and you say hands off.
Diagnosis.
That's it. See, admit to transfer to the thing. Okay. What do you want to do?
In the hands of, we have to confirm the diagnosis.
Confirm the diagnosis. Myocardial infarction is confirmed. Hands off. Transfer to cardiac catheterization lab with the diagnosis of myocardial infarction. Are you sure?
Yes, sir.
Finish. So detailed discussion. Okay. Show me the answers. Now this is important. He has done a great job. Big round of applause. Now let us say if he has really passed or not. This patient is having, can you hear me? This patient is having unstable angina and needs to be sent to the catheterization lab for percutaneous coronary intervention, PCI. The patient's chest pain is consistent with cardiac ischemia in description and duration. Don't be fooled by his run the other day. The EKG shows a classic valence wave consistent with acute LAD thrombosis causing unstable angina. Any cardiologists here? The thrombus occurs when a plaque ruptures, causing intermittent occlusion of the artery, which in turn causes myocardial ischemia and possible infarction. This is one of the rarest things. And he didn't budge. He didn't go to other things, you know. He didn't say CT scan of the brain and all that. So he really did the EKG. And why didn't you do the CT of the chest?
Lungs are clear, saturation is
Excellent. See, clinical diagnosis is very important. You got everything there, everything. Okay, the history should be focused on the potential cause of chest pain, including all that. To treat acute coronary syndrome, you should give full dose aspirin. How many tablets? How many milligrams?
325 milligrams, one tablet. Chew and
Enteric-coated?
enteric-coated.
Enteric-coated in acute?
Non-enteric-coated.
Non-enteric-coated. You said enteric-coated. Okay, that's okay. Okay, and what else do you give?
Atorvastatins.
Okay, and then nitroglycerin can be used, but you have to be careful when you use nitroglycerin because it can cause sudden hypotension. And also, you know, it is very important if you have a patient with left ventricular failure, you have to be very, very critical. So what do you do? Nitroglycerin can be used. You can start an infusion. And so he did a great job. Big round of applause. He is lucky. He is going home happily. Not every time it happens. I got another one. Anybody to take a challenge? Any kind of case you can select out of 86 cases I have? One more. I want to do one more at least. Maybe two, depending upon the time. Please. Anyone, any volunteers? Don't be shy. This is how we learn. Anybody? Anybody? Don't be. Commit mistakes here. You do commit mistakes here. Okay, I will take volunteer. What's your name?
Harideep, yeah.
Okay. You are a resident of?
I'm assistant professor, sir.
Okay. Wonderful. A big round of applause. He's a volunteer. He's our hero. Okay. Okay. Now I'm going back to the module here. All cases, you can pick and choose anything you want. What do you want to do? You want what kind of thing? Cardiovascular, dermatological, emergency medicine, environmental, family
neck pain
medicine?
with neck pain after car accident.
Pardon me?
49, sir. Case scenario 49.
Come here and you select the cases here. It's easy to.
Yes.
Ha. Good one. He selected neck pain after a car accident. Very common, very, very common. Why did you select this case?
So I'm an emergency physician, so it's
Okay.
This
Now
is a
here is the
challenge.
deal. 24-year-old female with neck pain after rear-ended multi-vehicular accident 3 hours ago. No neuro symptoms, anticoagulation or history of neck injury or surgery. So she comes to you with neck pain after vehicular accident. Okay. Now, what would you like to ask the patient? Talk to the patient.
I'll ask the symptoms. Ma'am, what is the
You
symptom?
can say, what's your name?
What's your name and what are the symptoms
Okay.
and when is the accident taken?
Okay. Because there is a lot of it. What's your name? You can say, you can start socializing, how you are doing. She says, my name is Karen Whitcomb. Those of you in the front, you can see that.
What are the complaints you are facing?
What else you want to ask?
I'll ask the complaints first, then I'll ask the negative history from
Okay,
there.
what is
Your present complaint.
what
Present
is your present complaint?
Code stroke, room 1. Code stroke, room 1.
Okay. I have neck pain and stiffness after a car accident.
So I'll ask the duration of the accident and the mode of incident, like what
Why do you
exactly
need the
happened.
incident? She said she had neck pain or that.
Even
We have to be very quickly diagnosed.
we have to know the mechanism of the
Okay,
injury.
then you can ask, previous medical problems. That's important, right? Previous medical. Huh? Yeah, can you type it?
Medical history.
Previous medical problems. That makes things easy for you. So you have to have a selective, specific question related to the clinical situation. Okay. I have a history of factor 5 Leiden mutation and I had a blood clot last year. I feel sorry for you. Not a lot of people know about this. Why did you select it? You want to select another case? No.
No, neck pain.
Good.
No, so this will continue.
No.
So factor
I don't
5.
know. How many of you know about this syndrome?
So factor 5 means patients are prone for more thrombus.
All right.
Clot
Okay,
formation.
okay. Any questions? Ask her.
And present medications, I want to ask. Present medications. What medications is on now?
The question is, what are the present medications? Excellent. Excellent. You need to know. Be smart. I am currently taking rivaroxaban and oral contraceptive pills. Oral contraceptive pills, again it rings bells. You really need to know about the vascular status, because they are notorious for the DVT. Right? Okay, then what do you do?
And as this is a female, I'll ask about last mentioned
Do you
period.
keep on talking to her or you do some sort of IV and labs and
I'll
monitors?
take the vitals and I'll do the physical examination of the patient.
Okay, then we have to put her on the monitor. Okay, in the exam, you just have to put on the monitor. First, stabilize. You want to put an IV?
Attached monitor.
Okay. And then the patient, okay, exam. Any other exam you want to do? You want to perform any kind of exam?
Because she's complaining of neck pain, I'll put an
Neck pain,
heart collar,
okay, neck exam.
Philadelphia collar, and I'll do the examination of the patient.
The neck exam says collar is in place, bilateral paraspinal muscle tenderness with spasm extending down into the trapezius. There is no C-spine tenderness. Any other thing you want to do?
I'll check for the upper limb and lower limb power along with the patient.
Excellent. So neurological exam. Okay. Let us see perform musculoskeletal exam. Tenderness to the lumbar paraspinal muscles without midline tenderness. So it looks normal. Perform neurological exam. Awake and alert. Deltoid bicep, triceps and all that, as well as hand grip. Everything is intact. You want to do psychological exam?
No.
No. Very good. Okay, now you have stabilized it. Now you had attached the monitor. It's almost 5 minutes the patient came. Let's see what happens. Here's the monitor.
Code 20, fast drive activated. Code 20, fast drive activated.
Well, the monitor is not functioning. So what do? Yeah, you need to have the monitor, okay? So let's see. Let us change and see what happens. Aha! You change the angle, you got the monitor. So what do you think it is? She looks normal.
Patient's hemodynamically stable.
She looks normal. So what do?
As patients complain of neurological examination normal and
bedside test. What bedside test you would like to do? Investigation.
Breath holding, chest X-ray is fine.
No, come here and see. No? Bedside test. What do you want to do? Imaging. You want to do a neck MRI of the spine? CT? What do you want to do? CT of the spine. Why CT? Why not MRI? Okay.
Along with the bedside complete bed picture.
Very good. So you are doing the CT of the spine and then order the CT of the spine. Perform. Let's see what happens. Well, this is the CT of the spine.
Grossly looks normal.
Any radiologist? Any neurologist? Looks normal. Is there any encroachment on the space?
No, looks normal.
Okay. So anything else you would like to do?
Patient here, PT appearance, coagulation profile.
Coagulation profile, excellent. See? Coagulation profile we are going to do right away. Investigate coagulation. Coagulation, complete bed count. Perform. This looks what? It looks okay, okay?
CBS looks normal.
Okay, then, and the lab work? Okay. PT is 11.8, PGT is 30.9.
Coagulation looks grossly normal.
It's okay? Okay, so what do you do? What is your diagnosis? Differential diagnosis.
So patient is on anticoagulants and so patient can be...
D-dimer? You want to do D-dimer?
It comes normal also.
Okay, let's see quickly. You call the neurologist or who do you want to call?
We'll call a neurosurgeon because of trauma case.
Neurology?
Neurosurgeon.
A neurosurgeon or a neurologist? Or are you, neurology is not available. You got the neurosurgeon is not sure why you call and what questions you have. They recommend that you consider CT scan of the brain if the patient has evidence of head injury. No? So, I'm just telling you, so this is again, it goes on. So I want to do one more case and we'll call it a day. Congratulations. Thank you very much.
Thank you.
One more, please. I will tell you there are so many modules and some of the modules is extremely difficult to pass. So, but this is the latest technology, how you can improve your clinical skills by committing mistakes here. You can ask any question. I will ask a simple question. And you will be amazing, amazing that she will answer any question to her. I will ask her, okay, patient, what do you want to ask? Well, who is the president of any country? Any country? India. Okay. Who is the president of India? I'm not sure about that. She said, I'm not sure about it. Can we talk more about my symptoms and how to manage them? So this is exactly what it is. You are interacting with the patient and the patient talks to you appropriately. And of course, I can also show you a very quick module of, the cardiac arrest in the emergency room. And with that, we'll call it a day. I know it has been a long day. And so I'm just giving you an opportunity to expose you to how much of advances we made in the simulation technology, especially with the AI. You want to do anything? Okay.
Dr. Douglas, please report back to room
The last one. We are doing last for the next 10 minutes. That's it. You can pick up anything you want.
Code 20, Path Lab activation.
How many of you would like to do another case? But I just, I superficially exposed you, to 2 cases, and it is going to be late for you. It's almost like 5:20. So I think, maybe it's a good idea to close. And so anyway, this is one of the modules that I brought here just to show you some simple thing. But this is like a 8-hour session for me, okay? And 8-hour session, we can go through any specialty. And only thing is, you need to have the attendance of the specialists. They can moderate. They can moderate the session, and then they can take care of it. So at least I just want to make sure that you are exposed to this kind of technology, And I'm sure in the next 2 years or 3 years, and I'm sure Guntur Medical College will adopt it into the curriculum. So do you have anything, any questions or anything? Any comments? I want to take the feedback from you. And again, I could have done 3 or more, modules with you, but again, it's not fair for me to hold you, for so long. We had a long, long day. So I think my take, what I'm trying to take out from all of you is, you are really genuinely interested in pursuing, in the medical field, not just like just a average physician, but a physician who is an expert in what she or he is capable of doing. And again, thank you all, and I especially thank Dr. Radhika, for bringing me here after many years, and I thank the principal, superintendent, and all of you on the faculty for giving me this opportunity. Again, I can always come back next year or whenever I come here. I make a promise if you're interested. I can also just, pursue your career. Keep in mind, your priorities are BLS and ACLS and PALS. These are the fundamental things. And thanks to the government of India who made the mandatory NELS, and I think you'll all be provided adequate and ample opportunity to pursue your career with the simulation thing. Thanks again, and I don't know, Radhika, anybody wants to say something? Or so in spite of the fact that we got an extremely busy schedule, all of you came here, and that means a lot to me. I talked to some of my classmates from 1968 batch. They were so thrilled, and I told them that I'm very proud, and I'm going to tell that I represent the 1968 batch. Thank you all again. Dr. Radhika, you want to say something? That's it, I already closed.
Thank you very much for all of you in resisting in such a short notice and making this program a success. Thank you. Thank you once again. All of you, please have the tea, snacks, and it's there in the dining area. All of you, please, it's there. It's arranged in the dining area.